Disorders of sexual development have often been considered as a medical and a social emergency. But what's been often ignored that it is actually an emergency for the doctors who rush towards going to the books to the various things as to how to evaluate an individual with DSD. iDSD will focus on the entire aspects of disorder of sexual differentiation, ranging from pathophysiology to classification to evaluation and management to iDSD, which is going to focus about disorders of sexual development, which is a very intriguing topic, a very interesting topic, which is often causing a lot of confusion with regards to evaluation and management. Website learning.growsociety.in, from which we are webcasting this event, where we have got multiple options available for learning in the form of our master pediatric endocrine course over 18 months, covering nearly now 100 modules on everything related to pediatric endocrinology. So if you want to learn, you've got each and every aspect which is there, using videos, using text, pre-test, case scenarios, and everything available. We have recently launched a pediatric endocrinology for postgraduate program, which again is covering a number of learning modules specifically for postgraduates for a 3-year period. All of you can have a look at a book which is available, and along with that we have the mobile application basically, which is covering in that perspective the various aspects of management of pediatric endocrine disorders, including the approach pathway, the management pathway, the personalized management care, and there are various ways you can use. It's a very intuitive form in terms of evaluating patients with different disorders of pediatric endocrinology. And these are available on Android and iOS.
The XX DSD, the major issue is the androgen exposure. And also we know that the female genitalia and external female genital appearance is a default. If at all there is no ovary, then and then still it will be of female genitalia. So XX DSD to happen, you need some androgen exposure to virialize that female genitalia. So any stereogenic defect which will lead to excess androgen production via diverting the precursors from the zona glomerulosa and fasciculata to the reticularis will ultimately lead to high androgen in form of high androstenedione, and they will virilize the female genitalia by doing clitoromegaly, labioscrotal fusion, and they will give rise to the DSD in an XX genotype. Apart from this androgen exposure and high androgens, there are a few genes which are responsible for the testis development. They might be inserted into that XX chromosome or an autosome, and they can also lead to the development of either ovotestis or a partly testis, resulting in an XX male. And this is also one of the causes of the XX DSD. And in ovaries, we know that there are some anti-testis genes like RSponding1 and FOXL2. So if these genes are deleted, then automatically, apart from the ovary, there is also development of a few tissues of testis which can produce testosterone, and this testosterone can virilize the external genitalia of female, giving rise to the ambiguous genitalia in an XX genotype. So most common is, of course, the stereogenic defect, which will leading to the high androgen production, which will lead to the virilization of the female genitalia in utero. And as Dr. Anurag rightly said, that labioscrotal fusion occurs by 12 weeks of intrauterine life, and after that there will be only clitoromegaly. There will not be any labioscrotal fusion. So in stereogenic defect, we know that the zona glomerulosa produces aldosterone, zona fasciculata produces cortisol, and zona reticularis produces DHEAS, which will be converted to the androstenedione, which is a major androgen of ovarian origin. So any block in either cortisol pathway or aldosterone pathway, which will ultimately divert all these precursors to the last, that is zona reticularis, giving rise to the high androgens in intrauterine life. And we know that the most common defect, the 90-95% of the all stereogenic defect in an XX genotype is 21 hydroxylase deficiency. And we know that this deficiency might be mild, moderate, or severe. And depending on this enzyme deficiency, either it will present as classical salt wasting, or a simple virilizing, or a non-classical CH. In classical salt wasting, the enzyme activity is less than 1% or practically undetectable. In simple virilizing, the enzyme activity is between 1 to 10 or 15%. And in the simple virilizing, the enzyme activity is approximately 20%. So depending on the quantitative 21 hydroxylase, it will present at different part of the life. So 21 hydroxylase will lead to salt wasting, but in an XX individual, it is caught before even salt wasting happens due to the genital atypicality or genital ambiguity. And in this, due to blockade at the 21 hydroxylase, the proximal metabolite, which is 17 hydroxyprogesterone, will be elevated in hundreds and thousand times more to the normal limit, and hence the 17 hydroxyprogesterone is a screening investigation of choice to detect the 21 hydroxylase, and it should be done only after 42 hours of life, preferably in the third day of life, because of the normal surge in all hormones, same as the thyroid and other hormone occurs. The next most common, which is responsible for the 5% of the all XX DSD, is 11 hydroxylase deficiency. And we know that this 11 hydroxylase is present in, again, the cortisol pathway as well as aldosterone pathway. But though it blocks the aldosterone, the proximal metabolite, that is deoxycorticosteroid, is also a potent mineralocorticoid. And it is the reason that due to this high DOC level, the patient or the child will have hypertension. But in the initial 1 to 2 months of life, we know that there is mineralocorticoid resistance. So this 11 hydroxylase deficient child might also be presenting with the salt wasting variety earlier, followed by the development of the hypertension later in life. So hypertension again is a hallmark if the patient presents later in life, and 11 deoxycorticosterone level should be done if we are suspecting 11 hydroxylase deficiency. More proximal defect, that is 3-beta HSD, and we know that the 3-beta HSD is one of the most important enzyme because it affects all three pathways of cortisol, aldosterone as well as androgens. And we know that the adrenal gland comprises of 3-beta HSD2, and we also have 3-beta HSD1, which is present in the periphery, which is present mainly in the liver. So 3-beta HSD2 deficiency in the adrenal gland will result in the excess DHEAS, and this DHEAS will go to the liver and it will be converted to the androgens via this 3-beta HSD1, and ultimately they will virilize the female genitalia. So this is a mechanism where 3-beta HSD2 deficiency will result in the female genital virilization. It will present as salt wasting, but this salt wasting might be delayed as compared to the 21 hydroxylase deficiency. And 17 hydroxypregnenolone is the investigation of choice for the screening of suspected 3-beta HSD2 deficiency. Again, as earlier discussed, POR, that is oxidoreductase, which acts as an electron donor to the three enzymes, that is 21, 17 as well as aromatase, will lead to the mild salt wasting as compared to the classical salt wasting of 21 hydroxylase deficiency. And the ratio of 17 hydroxypregnenolone to the cortisol or to the 17 OHP, there are different cutoffs which are helpful to diagnose the POR deficiency. Again, aromatase is the same as POR. And we know that the aromatase enzyme is present also in the placenta. So aromatase deficiency will lead to excess androgen production even by the placenta, which goes to the mother. And these androgens can virilize the mother in pregnancy. So there is typical history of change in the voice, muscularity, excess hair growth in the mother, which simultaneously subside after the baby is born, is typical and characteristics of the aromatase deficiency. Now we know that the 21 hydroxylase deficiency is very common. It is seen in approximately 1 in 20 to 30,000 female live birth. And we know that the defect is at the level of 21 hydroxylase, and depending on the quantitative presence of this enzyme, it will manifest as either classical or simple virilizing or non-classical, which is present as PCOD picture later in the post-pubertal life, in which there is low cortisol and low aldosterone, and manifest include prenatal virilization followed by the pigmentation, and salt wasting typically happens after second week of life, because we know that during first 2 to 3 weeks of life there is aldosterone resistance. So baby will not lose salt even if baby is absent or baby is deficient in the aldosterone level as well. 17-OHP is the hallmark, and we should send the 17-OHP whenever the patient presents with the atypical genitalia or in salt wasting crisis. And 17-OHP is usually more than 1000 nanogram per ml. And if the 17-OHP is borderline, then we should suspect other deficiencies like 3-beta or aromatase as well. 11-beta hydroxylase deficiency is observed in 5% of the total virilized female of the live birth. And we know that there is low cortisol but high mineralocorticoid due to excess DOC level. Again, due to the cortisol deficiency, there will be high ACTH leading to the pigmentation, and mild salt wasting can also be observed in the early first or second month of life, followed by hypertension in the later life. So hypertension along with hypokalemia with metabolic acidosis is the metabolic alkalosis is the hallmark of the 11-hydroxylase deficiency, and deoxycorticosterone is investigation of choice. 3-beta HSG2 deficiency again can cause both. It can cause virilization in female resulting in XX DSD. It can also cause XY DSD because the peripherally converted androgens are not that sufficient to cause the normal development of the male genitalia. So 3-beta HSG2 deficiency can cause both XX DSD as well as XY DSD, in which defect is at the central level or more proximal level. But due to peripheral androgen production, the female genitalia will get virilization. Again, these children are also deficient in the cortisol as well as mineralocorticoid. So we should be supplementing them as soon as possible. Mild salt wasting, preferably majority of them are observed in maybe second month of life. And high 17-hydroxypregnenolone is the initial screening investigation of choice. Of course, there will be high DHEA because DHEA is just proximal step to the 3-beta HSD2 enzyme. So we can do DHEA to see whether they are high or not. And this can also give an idea regarding the possible 3-beta HSD2 deficiency. POR, that is cytochrome P450 oxidoreductase deficiency, is presents with the, of course, female genital virilization, but the function of this P450 oxidoreductase is to give electron donation to the other three enzymes, that is 17 and 21 hydroxylase along with the aromatase. So the deficiency of PR again depends on the quantitative, that how much this enzyme is deficient, and there is variable amount of 17-hydroxyprogesterone, 17-hydroxypregnenolone. So ideal is genetic investigation, though we can see the ratio of 17-hydroxypregnenolone to cortisol as well. Due to aromatase deficiency, there is also a history of maternal virilization, and mild salt wasting can be observed depending on the how 21-hydroxylase enzyme is deficient or not. High 17-OHP level is also observed because of the 21-hydroxylase is absent or very low in these individuals. Again, aromatase presents with the same, but the hallmark is high androgen even in the mother. So maternal virilization history is typical, and we should be asking whether there was any voice change, there was any hair growth during the pregnancy or not. And it is an early onset, and 17-OHP can be mildly elevated, not to the level of the 21, but yes, mildly elevation of 17-OHP as well as typical history of maternal virilization will probably point out towards the aromatase deficiency. And the aromatase deficiency is typical of high androgens in the intrauterine life, followed by estrogen deficiency, because we know that this aromatase enzyme converts all our androgens to the estrogen. So in the later life, there is a history of delayed puberty followed by the ovarian cyst due to faulty estrogen production and high androgen production. So early life virilization, later in life estrogen deficiency, infertility, and delayed puberty is observed, and this is the typical of aromatase deficiency. So this is the table of stereogenic defect which can lead to XX DSD and the female virilization. The most common is 21-hydroxylase. So of course, we should be doing 17-OHP hydroxyprogesterone as the first line investigation whenever we suspect the virilized female with absent gonads and Mullerian structures present on the ultrasound. Rest all are comprises of approximately 4 to 5%, so they are very rare. But still, if we found borderline elevated 17 OHP or the delayed salt wasting or with hypertensive virilized female, then we should suspect all other variants of the stereogenic defect, and accordingly we should screen and investigate the child. Now, as I said earlier, that the XX DSD is an act of commission. We need something from outside in form of androgen to virilize that genital female genitalia. So sometimes it happens that maternal androgen can cause the virilization of the fetus by crossing the placenta. So luteum of pregnancy and ovarian or any adrenal lesion on the maternal side can also lead to high androgen production in the mother, which crosses the placenta and virilize the female fetus. Danazol, of course, is a known to cause the female genital virilization, and there is a typical history of both maternal virilization as well as fetal virilization. So this is again a differential diagnosis to the aromatase deficiency, and it is generally a progressive virilization, and depending on the androgen exposure, the virilization extent is seen in the fetus. Now, if the ovarian antitestis gene are deficient, or any gene which can give rise to the testicular tissue development, it can also cause increased androgen production in the female fetus, and this can lead to the virilized female. Majority of them are having a part of testis gene, that is either SRY or any other distant gene, which lead to the development of fine testicular tissue along with the ovary, resulting in either ovotestis or dysgenetic gonad, which are able to produce some androgens which can cause female virilization. So NR5A1 again is responsible for the adrenal development as well as gonadal development. So any NR5A1 defect, or earlier called as stereogenic factor defect, will lead to the XX ambiguity with adrenal hypoplasia. FOXL2 is an ovarian gene, so any, as well as it works as antitestis gene. So deficiency or mutation, inactivating mutation in FOXL2 can result in defect in ovarian development, followed by the increased androgen production. WNT4 and R-sponding1 gene are also classically required for the ovarian cell development as well as stroma development, and any mutation in this gene can also lead to the XX gonadal dysgenesis, resulting in the virilized female. So SRY transposition, we know that the most important gene in the testis development is of course SRY, which is normally present on the Y chromosome, but many times it happens that this SRY gene can translocate to either any X chromosome or any autosome, which can result in the production of the testicular tissue as well as the androgens. Though SRY is the only one gene, so we do not have typical testicular development, but still there are some testicular tissues which can virilize the female and which can cause the issues regarding to the gender identity of the female fetus. So manifestation, again, SRY insertion are typically having some testis. There might be irregularly shaped testis which may be present in the abdomen or the inguinal canal or even in the testis, but these are dysgenetic gonad. They can produce some amount of testosterone, but not the typical sperms and the semen in the this type of SRY transposition male, but still they are reared as a male. These are called XX male. Primarily they are infertile male because there is no development of the sperms, and this SRY gene induced androgens can inhibit the Mullerian structures. So there is no Mullerian structures. So phenotypically they are male, but genotypically they are XX. So they are called as XX male. NR51 mutation, again, as I told earlier, it is responsible for the adrenal gland development as well as testis development. So NR51 activation will lead to the development of the testicular tissue along with the excess androgen. And we know that homozygous NR51 mutation is typically leading to the XX male, but the parents of this homozygous NR51 are heterozygous, and accordingly counseling is required, genetic counseling. It is present generally in the 10 to 20%, and in this NR51 defect, if it is heterozygous, then adrenals are rarely affected. Only affected part is the gonads, and it will result in the XX male. SOX9 duplication will again lead to the SOX9 is a distal gene compared to the SRY. So SOX9 duplication will lead to the inhibition of the FOXL2, which is responsible for the ovarian development. And ultimately it will lead to testicular development, though karyotype is XX. So the patient might have a normal genitalia of a male with infertility due to absence of other genes like SRY and FGF9, which ultimately leads to the normal male fertility. So these are again XX male due to SOX9 duplications. SOX3 expression again, which will ultimately lead to its distant counterpart, that is SOX9. It will increase the expression of the SOX9, lead to either testicular development or over testicular development, and fertility is variable. But theoretically, it should not, the XX male due to a SOX3 expression should not be fertile. Now coming to the ovarian gene, which are responsible for the normal ovarian function, and these are WNT4 inactivating mutation, which will lead to defect in the ovarian development, which will lead to either defective ovary, that is streak gonad, or testicular development or ovotestis. And this WNT4, we know that it is required for the kidneys as well as lung development. So they might have multi-system involvement in form of either renal or renal and lung development along with the XX virilized female counterpart. R-spondin1 is the one of the distal most genes in the ovarian development, and we know that the R-spondin1 inactivating mutation will lead to again the defective ovarian development, leading to the decreased estrogen production and virilization of the female fetus. The typical phenotypic appearance is either testicular or over-testicular DSD along with the palmoplantar hyperkeratosis. But sometimes, many times it happens that this R-spondin1 or WNT1 gene defect might get discovered at the later life whenever there is an infertility issue or delayed pubertal issue in the female, because many times it happens that if androgens are not there during the time of the intrauterine life, then this might be born as the normal female, but ultimately they will be infertile or there might be delayed puberty as well. So these are the genetic defects. Ultimately, they will be infertile whether they are raised as male or a female, because they have not the proper list or proper array of genes which are required for the normal gonadal development and normal gonadal function. So again, XX DSD is an act of commission. We need some androgen to virilize the female genitalia. So either they can come from the fetal adrenal or fetal ovary, or from the mother, or from the drugs.